Right. I think we're going to start because getting people back from lunch is going to be very difficult. And we've got a set time for the session. So I welcome you all to the Hepatopancreatobiliary Surgical session of the 22nd Shaukat Khanum Cancer Symposium. This is going to be an interesting session because all we're going to talk about is the controversies that we face in our daily practice. And the aim is that we learn something about how complex these decision makings can be. With me is Mr. Robert Sutcliffe. He's a consultant hepatobiliary surgeon, lead for hepatobiliary surgery in Queen Elizabeth Hospital, Birmingham, UK. And I'm Dr. Irfan Kabir, who's a consultant hepatobiliary surgeon at Shaukat Khanum, Peshawar. Our first speaker doesn't seem to be here. So we're going to start with Mr. Guido Torzilli, who's with us online. And he's going to talk about resection versus living donor liver transplantation for resectable HCC in a cirrhotic patients, and do the cost of transplant justify the outcome difference in resectable cases. So we're going to put him online.
Yes, I am. Can you hear me? Can you hear me?
Guido Torzilli online है, वो online है.
Hello? Hello?
Guido, can you hear us?
I can.
Thank you so very much. So you're just going on your Zoom link. So
yes,
if,
I shared this. I shared it, and I can already started my presentation. Okay.
So we
Is it
can
okay?
hear you and we can see you. So the floor is yours.
Thank you very much for the invitation. I say hello to Robert and to you for chairing the session, and to all the guys that are there. The talk that you already addressed me, then we move on to stay in time. And disclosure, I have nothing to disclose except that I am not a transplant surgeon. That could be a bias about my talk. Then I will move. Why surgery? Why surgery for the ACC? Because it's the best local regional treatment. It can provide the removal of the segment in which a tumor is, so selectively, but including the microsatellites and the eventual microvascular invasion. The technical solutions are various. We propose the compression. It's a reversible technique that allows us to disclose the segment or subsegment anatomically, and it provides us all the other technique that has been tested in this sense, better long-term survival than the non-anatomical resection, and also local recurrence free survival higher than the non-anatomical resection, while the recurrence into the liver, this is the biology of the disease, then it doesn't change whatever is the anatomical or not. This kind of technique is now approached also in minimal access liver surgery, and it's going to publish in the first release in this sense on surgical endoscopy. In that sense, we profit also of the use of the ICG in a negative staining modality. The novelties in surgical oncology that we proposed are the fact that we propose also for the colorectal liver mets are the fact that we detach the tumor from the vessel when it is not infiltrated, and the R1 vascular behave like the R0, better, much better than the R0s, R1 parenchymal. That this means that R1 vascular is oncologically suitable also for ACC other than for colorectal liver mets. This enable us to deal with complex disease in a conservative way, which is furthermore most important in a patient with cirrhosis. Like in this patient, it's a huge tumor in the central part of the liver, imprisoned in between the major vessel, but it was possible to remove it selectively with a liver tunnel, with detachment from the vessel and also sacrifice of the middle hepatic vein profiting of the communicating vein that when there is a vascular invasion, allow to avoid major hepatectomy in huge tumor like this one, invading the right hepatic vein in contact with the middle. There is no inferior right hepatic vein. The future liver remnant would have been only 22%, not enough for after a major hepatectomy. The communicating vein were traced, and at the end, a few grams of liver tissue were removed together with the tumor. That when surgery may be futile, this could be in the event of tumor very small. In example, tumor ACC less than 2 centimeters, we used to let them undergoing ablation, and it was already pointed out in 2008 on Archive of Surgery. The same here, Livraghi was showing the sustained complete response in this patient with the ablation. And there is a reason why the microsatellite below 2 centimeters as a rare event of micronodular lesion. Besides the guidelines, we are fighting with the guidelines since long time, because resection is has a marginal role even in the latest one that I have just shown, and the background is a background which is wrong, because the ones it was introduced sorafenib for the advanced disease, they were not recruiting the surgical patient. The recruited patient were, as they wrote, not eligible for surgery. So they missed the patient with advanced disease, but operated, that were not undergone to their outpatient clinic. They couldn't see that. Indeed, we showed in 2013 that half of the patients operated in tertiary referral center about ACC were exactly out of the guidelines, BCLC B and C. And if you look at this long-term survival, the BCLC B at the 57% survival 5 year with 27% disease-free survival. And of course, we are talking about the universe of presentation. Multiple bilobe, multiple lesion can be this satellite, other scattered, and infinite number of lesions. Then we have to find which is the subset of the patient that could profit. And we together with the group in China, we were showing almost the same cutoff, less than 4 lesions, up to 4 lesions, and less than 6 centimeters for them, 4 lesions and 5 centimeters. But anyway, for this patient, the median survival is much better than that is recommended for after TACE, while just above these limits, the median survival that we observed was 20 months, similar to that of TACE. So for this limit surgery under that, it seems justified. For BCLCC, 38% for survival at 5 years and 18% disease-free survival in that paper. That has been confirmed in all the results, at least for those patients with tumor within, tumor thrombus within the liver, up to the major branches, and the segmental one. And this confirmatory result has been reported in literature several times in these years. And also the guidelines, the other guidelines changed accordingly. We were just asking to insert this aspect in the guidelines of the EASL, BCLC, just saying that there was a population that they were omitting, that they missed, and it should be pointed out in the guidelines. These unseen patients remain unseen according to them because the proposal was ignored. And unfortunately, we may say that they were wrong, because in these last 10 years, the patients who underwent surgery were still having the chance of surviving long time, while the sorafenib patient had a clearly inferior prognosis. The transplant, well, I move to the conclusion. The transplant is, I found something that for ACC was introduced in 1991 by Iwatsuki in Pittsburgh, and Bismuth was also depicting a sort of Milan criteria in 1993, and of course definitely Mazzaferro in 1996 with the prospective cohort on New England Journal established the results that have been always reproduced, and of course the expanding criteria given the exciting findings were attempted. Although the ticket cost more anyway, there was some benefit, although we were moving all out of. Then the downstaging to get the patient back, and then increasing the possibility to operate those who are over the Milan criteria, which remain anyway the main criteria, although evolved with, as you will see, with the alpha fetoprotein, the number of lesions can be more, and the combination of the max tumor diameters, number of lesions, and alpha fetoprotein depict the most recent criteria that has been also this really, instead of our proposal, were immediately inserted in the latest release of the BCLCC, including also in some part the intermediate ACC. And for the relapse after surgery, it seems that transplant in this Italian study, multicentric, which we will join, is better than all the other local regional approach. Anyway, if you look still now, in the guidelines, the transplant remain for those unresectable, for those with a poor functional reserve. So it's not really clarified the role of, unless there would be clear indication that should not lead the patient to surgery. And if you move to the living donor environment, mostly in the east part, where you are, the functional reserve is leading, and the surgery has a more prominent role than in the Western countries, and I may say that is closer to my attitude. Then moving to the conclusion, I may say that we cannot forget that in the real world, on an intention to treat, and given the improvement of surgical care, surgery is not so bad in terms of offering chance of cure for the patients. And even for the relapse, we have shown on JAMA surgery recently that with using the algorithm and the artificial intelligence, according to the large database of the Hercules Group, is an Italian database about ACC, we saw that surgery could be a good solution for the relapse, and in the real world, only 1.7% of patients with relapse after surgery received a transplant, contradicting a little bit those enthusiastic papers that were showing that this should have been the best treatment for the relapse. Even treatment hierarchy, to me, is the best way of looking at the panel of therapeutic options that we have, and surgery remains still important for most of the application, and even more than transplant in the case of advanced disease. Then multidisciplinarity is fundamental for that. Once there is such kind of, and of course the inclusion also of the transplant surgery in the team should be indeed it should be balanced, representative of everyone, checking all patients, and should challenge the guidelines. For sure, the emerging role of the systemic treatment in a neoadjuvant and adjuvant setting, the expansion of the living donor in a robotic approach, which are not data that should be, of course, look with caution, but should not be considered for the relevance of the number that they are showing and the safety of the procedure that they have obtained. And finally, let me foresee that in the future, probably we will have the organ printed out. And then the landscape that I have just shown is going to change, and probably I will be considered a primitive guy. Thank you very much for your attention, considering only the fact that for the cost and numbers are already ruling the follow chart, as you have seen, and this will proceed further. But if what we discussed is the direction, the cost may slow down the process, but hopefully not stop it. I mean, the progress of research is not slow, is not stoppable by the, should be not stoppable only by the criteria of the cost. Thank you very much for your attention.
Thank you, Guido, for such an entertaining talk. I think this discussion is going to carry on for a while, whether resection or transplant should come first for those who are resectable and there's some cirrhosis in it. We are going to take the question and answer sessions later on, unless you're in a hurry and you want to take some questions now.
No, I can be here.
Okay, thank you so much.
If you want.
Thank you. So we'll take the question and answers in the end.
Thank you.
So the next speaker we have is Mr. Jamil Ahmed, who's a consultant surgeon at Northampton General Hospital, and he's going to talk to us about synchronous liver and colorectal resections for colorectal liver metastasis. And we want to kill two birds with one stone. So he's going to talk to us about the intricacies in the decision-making process.
Thank you very much, Irfan, and organizing committee, and all your organization to giving me an opportunity to talk about this topic. My name is Jamil Ahmed, and I work in Northampton as a colorectal surgeon. We do lot of laparoscopic and robotic sections, and we do have a lot of involvement with the HPB surgeons. I have nothing to disclose. Let's start with the definition. Synchronous colorectal cancer with liver mets, or the one which are generally present at the diagnosis, and the literature also says about the cancer or the mets in liver within the 3 to 12 months. There was not a lot consensus about this definition till a few months back. This European consensus come up with the terminology, and it also worked on the diagnosis and the management of patients with synchronous colorectal cancer and liver mets. And they defined that all the mets which are found at the time of the diagnosis of the primary tumor or on the perioperatively, those are the only synchronous tumor. Any tumor which is found within the 12 months from onward until 12 months is called as early metachronous, and then the delayed after the 12 months. This is the new definition, probably, which will help to make the further data correction and help to define, perhaps it will change a lot of things in terms of the way we look at their outcomes. When you look at the colorectal cancer, it is the third most common cancer worldwide, and accounts about the 10% of the cancers. Most common site is liver, and it is estimated that about 50% of the patients develop colorectal mets in the liver in their journey of their cancer diagnosis. About 12%, 15 to 25% patients do have synchronous liver mets when they are diagnosed. More common in male patient. When we go back further into the detail, then we look of those patients who present with the metachronous cancer, only 10% are resectable, and majority will go for a chemo, and then the decision will be made about their further plan. So 10% people who undergo surgery, they have a completely different outcome, because the surgery is the one of the important factor about the survival, and those people will have a higher survival rate, up to 30 to 45% at 5 years. But if the people who do not undergo resection, they have a completely different outcomes. This is one of the early paper which showed that there is a less likely to get any improvement in those patients who would not have a resection. And they also emphasize the fact that the role of resection is important in order to achieve any sort of survival. So this is a similar emphasis. If we do not do any surgery, the likelihood the patient will die within from 6 to 12 months time. If patient does not go any type of treatment. However, if the patient goes for a chemo or any other non-surgical modalities, they will have a survival up to 12 months. Again, it's very minimal survival for 5 years. People who undergo resection, they have a higher likelihood of survival. So how to do the surgery? And that is being debated, and that been debate, and probably it will go further into more complex discussion in the future when the robotic approach, laparoscopic approach, and all those come into play. But for a terminology point of view, we know that there's a classic approach, which is which is also called stage, and there's a combined approach, which is simultaneous approach, where you take both primary and liver mets together, and the reverse approach. And I must say that while I was going through this literature, reverse approach, which is but one of the approach coming into more significant way and becoming one of the important choice, especially from the surgical point of view, from the HPB surgeons, and it will come in more detail later on. There is still controversies, and it depends upon what you look, how you look at it, what literature you look, what center you look, and everybody has their point, and everybody has their data to support their points. So if you have a cancer patient who are colorectal cancer with synchronous, then we have all three approaches possible, applicable, decided based on if they are resectable or not resectable. This is a slide just to show you that actually the resection is becoming a very important modality, and all the three resection type which we talked about are important, and we need to find which patient would be suitable for which approach. So what is the benefit? What the school of thought who thinks that the simultaneous resection should be done, and this is what they say, and that's proven by the data. They say it's efficient. You do the early treatment of all the disease in one go. It is a low cost because 2 admissions, 2 length of stays, and all the complications, and there's less chance of progression of disease while you are waiting for our second operation, especially when you are on the chemo. And then physical, I'm not sure, but physiological trauma is less. And they also say there is no consensus. So why not we make a consensus to do them before? And in some cases, you will completely avoid giving any chemo. And now, because the HPB surgeons are becoming very efficient, there would be a selective clamping of the portal pedicles and maneuvering, Pringle maneuver. So it's less likely that it will have a major impact on the splenic blood supply and the blood supply to the vessel, and anastomosis risk are less. And these are doable, and this should be the part of the game. What about the people who are more into the stage of procedure? They say there's less priority time during each operation and less anesthesia. Obviously, they are talking individual operation, not joining both together. They also evidence that there is a less perioperative morbidity and less trauma, especially when you are doing an operation on one side rather than operating on 2 different sites. The also arguments that when you're giving the chemo, you are controlling the tumor, and after resection of primary, you will have a more understanding of the disease, and you will be more have a better selection for the regime for the chemo. And if the disease progress while your patient is on the chemo, and then it's a self-selection, then probably surgery is not going to save him, then maybe it's time to think about not actually performing surgery. They also think that the patient who are diagnosed both together, sometimes you miss small lesions somewhere within the abdominal cavity or sometime in the liver, which are not detectable at the time of the initial procedure. So if you wait, you will have find them later on. Let's go to another terminology which we use about low risk and high risk procedures. So there are two aspects in the both aspects are related to the colon as well as the liver. So low risk colorectal side is the one which right side is the colon. Sigmoid colectomy without diversion or stoma is also called as a low, is graded as a low grade, but this is a one factor. This can be very high grade or high risk to a patient who had a lot of morbidities. So you have to look as in a whole picture, but in a single factor, it's a low risk procedure. And high risk are the rectal cancers and the cancer below. Similar, low risk hepatectomies or partial hepatectomy, left hepatectomy is the high risk or the right sided. There are some contraindications where you should not be thinking about the synchronous operation. These are mainly those with the primary very symptomatic, or for those where there is a issue with the liver failure. So if we look at how you're going to approach, we got a primary, we need to look at it primary. Is it symptomatic or asymptomatic? If it's symptomatic, okay, look at the liver, how the liver look like. If the liver is resectable, yes, okay, then you go next. If the liver has a disease more extensive or less extensive, limited, then the play of or the option of either do chemo or primary surgery comes. But if you look at the hair, it is very common to see that chemo is one of the most important part, but obviously you can give the chemo and come to the stage one stage operation. This is a slide just to highlight the fact that the chemo has but it is a metachronous tumors that if you do upfront surgery or upfront chemo and then surgery, there is a survival risk is the same, though the postoperative complications are slightly more with the chemo group. This is the consensus from the multidisciplinary international meeting, and they have published that how to approach, and depending upon resectability and the unresectable, they given a pathway how you're going to follow. And again, you will see the synchronous is an option for an asymptomatic tumor where both primary and the metastasis are small and resectable. So then it depends upon factors from the it is just a summary of the previous slides, that what about the primary, if the symptomatic, asymptomatic, where is the site, right, left, rectum. Similar applies to the liver, resectable, unresectable, and what is the condition of the liver, and what is the function of the future remnant of the liver. So these are the important aspects to making a decision. And one of the important aspects is the patient, what are their general conditions and comorbidities. This is the paper which look at those aspects, and they come to the conclusion that the comorbidities and major section, if they are there, the likelihood the patients mortality and morbidity is much higher in this group. But if you have a less comorbidities and minor operations, likelihood that this is a good combination. This is another slide which actually emphasizing the same, and I will just skip it because of the time. So this is one of the meta-analysis which look at the 12,000 patients, and in which there are 5,000 patients have had a simultaneous resection, and they highlighted the fact that the higher there were resection were more right-sided. They had a more minor hepatectomies and low rate of bleeding, and obviously short length of stay, and there was no significant difference. But the problem is this: there's a major selection bias. And it is not supported by the high quality randomized control trial, and stage procedure of the complex surgery is a still important aspect. This is another meta-analysis which is looking at the long-term outcome, and it says that there is no major difference between the two approaches. I think this is the most recent paper, and probably this is going to this consensus is going to provide the base for the future practices. But it highlights that systemic therapy is one of, before the surgery, is most preferred. However, it does not deny the simultaneous resection. This is one of the American nationwide paper, wide data from for 10 years, from 2004 to 14, of 83,000 patients. But although it looks huge, but actually the number is 6% of those patients had out of those simultaneous resection. So it means that there is a selection about that. But generally, looking at the years and years, there is an increase in the combined procedure. And there is also the increase in the picking up the patients with the higher risk. It has improved shown that it has increased improved the mortality, as well as length of stay is much better with the combined approach. So I'm going to skip. This is another aspect from the surgeon point of view. And this is another prospective study which look at the three different aspects, and they have shown that there was actually statistically no difference between the surgical groups, and the 3-year survival was also not a problem. This is one of the proposal which is now probably going to recruit the future patient, looking at all three different groups, and going to have a optimal outcome based on the patient reports and the short-term and long-term outcomes. So there are a number of factors: comorbidity, stage of the disease, burden of the disease in the liver, and preoperative chemotherapy, and the function of future remnant, which play important role to making any decision. This is regarding a couple of slides, last 2 slides. This is slides to show that there is a role of minimal access surgery, and there was a consensus guideline from the Southampton which showed that it is a complex. It makes procedure more lengthy because you are going to operate on 2 different sides, but it should be offered to the patient who had a peripheral liver disease with the right-sided with the operable colonic cancer. Obviously, there are challenges about the ports, about the area, and that's why there are some papers which have suggested that open and hybrid approach, where you do one part laparoscopically and you come back to do a liver open. And this is one of the very good paper coming from South Korea, which they have done almost every procedure laparoscopically, and even they've done some rectum, and they have shown that it is doable, and it has to be done with the highly experienced centers with significant better, and it can give you significant better outcomes. Obviously, no talk will be completed without including robotic surgery, and there is a data that which is very limited, but it says that it's safe and feasible and can be done. But in the future, more data will come. So in conclusion, I think overall it proves that overall survival, bleeding complication, and disease-free survival and chemotherapy complications are the same between the groups, though there is always some selection of the patient. So there is always a controversies and bias in this data, which prevails every time when you look at any paper. But the key is the biology of the patient, the selection, and the how and the stage of the disease. So two birds can be killed with one stone when this is deemed feasible by the MDT and patient factor along with the disease factor with the appropriate expertise. Any of these factors are compromised, then it can be a disaster and can cause a major impact on the patient outcome. Thank you.
Thank you very much. It just shows how complex the decision making can be for these kind of things, and a wrong decision can be catastrophic. Thank you very much. We're going to take questions at the end. I'm going to present next. We're going to shift from the liver to the pancreas now. And the next person on stage is going to be Mr. Robert Sutcliffe. He's a consultant hepatobiliary surgeon. He's head of department for hepatobiliary surgery at Queen Elizabeth Hospital, Birmingham, UK. He's one of my mentors as well. And he's going to talk to us about fast-track surgery for resectable pancreatic cancer and its implication for resource-limited healthcare setting. Just for those who don't know, there's a huge debate at the moment in the HPB world regarding going upfront surgery within 2 to 3 weeks of presentations versus chemotherapy first. So Mr. Sutcliffe is going to talk to us and convince us that surgery is better than chemotherapy. Thank you.
Thanks, Safan. Thanks for inviting me to talk. It's a real honor to be here. Just to be clear, I'm not going to be fighting surgery versus chemotherapy. I'm going to be talking about surgery versus stent, followed by surgery. Okay. So I'm going to talk a little bit about the history of a Whipple procedure. For some of you will know what's involved in a Whipple's procedure. What does fast-track surgery mean? What are the advantages and what are the challenges that we faced in introducing fast-track surgery within our unit, and how to select patients. So patients with pancreatic cancer in the head of the pancreas or other malignancies within the periampullary region, when it's localized, the treatment is pancreaticoduodenectomy. So that's resection of the pancreatic head, duodenum, bile duct, and gallbladder. In combination with chemotherapy, some patients can achieve long-term survival and even cure in some patients. So the operation was first described in 1935, so almost a century ago. And when Whipple described the procedure, he was aware of the issues of jaundice and the risk of operating on patients who are jaundiced. And so actually, some of you may not be aware, but the original Whipple procedure was a two-stage procedure. So if you look at the pictures on the right of the screen. So the first procedure was so you've got a patient with a tumor in the head of the pancreas. The first procedure was to drain the gallbladder into the stomach so that bile drains, and then you do a gastroenterostomy to allow stomach to drain. The jaundice clears, and then he does the Whipple procedure. If you'll notice, he leaves the gallbladder in. You'll also notice that he doesn't do a pancreatic anastomosis. So he's made life easy for himself, but this was 1935. But he was aware of the issues of jaundice at that stage. So this is, I think, it's early series, and the point of this slide is to demonstrate that in this series of patients, there was a 38% mortality. So almost a 1 in 2 chance of dying from a Whipple's procedure in 1935. Surgery in jaundice patients. So around the same time, 1936, this paper came out in the BMJ, and you will all be aware of the pathophysiological effects of jaundice. You'd have been taught this at medical school. So patients have coagulopathy, liver dysfunction. It can cause acute kidney injury. It can affect the immune system and cause malnutrition. So it's an issue to operate on patients who are jaundiced, or it was in 1936. This is one of the earliest series of Whipples in a big, sort of relatively high volume center in the Mayo Clinic in the sort of 1940s, 1950s era, to give you an idea of the progress made over the 2 decades. But the mortality was still high. It was 19% better than the original Whipple series. One of the frequent complications was elevation of blood urea, which I take to mean kidney failure, which is almost more than half of the patients. And this is a problem with operating on jaundiced patients in that era. So some of you may not be aware, but ERCP was first implemented in 1968. So following this, it became standard practice to put stents into patients with pancreatic or distal cholangiocarcinoma to relieve the jaundice before you perform the Whipple's procedure. ERCP is associated with some potentially significant, even life-threatening risks. So the two main issues with ERCP are pancreatitis and cholangitis. So we're relieving jaundice, but we're exposing the patients to risks. So this meta-analysis was published in 2002. So it covered a period of time, sort of in the 1980s and 1990s, and there were 23 studies analyzed, of which 5 were randomized trials. And the randomized trials are in this table, in this forest plot here. So the 5 randomized trials were all small numbers of patients. But when they analyzed the data for both the randomized and non-randomized trial, the patients who had Whipple's procedure without preoperative biliary drainage had lower morbidity, so lower complication rate if you go straight to surgery without stenting. So in this table, I'm not sure you can see this very clearly, but I'll go through it with you a little bit. So the mortality rate. So the first thing to point out was in this meta-analysis of all these studies, these were patients who were being operated on for malignant jaundice, but the resection rate was small. It was 15% of patients in the biliary drainage group had a resection. The rest had bypass or abandoned laparotomy, and it's the same in the other group. So about 1 in 6 patients were resected. So this is not this study doesn't look at Whipple's. It looks at all those operations, including the bypasses. And some of the mortalities in this study occurred preoperatively. So they occurred due to complications related to biliary drainage. So the next step was to then perform a larger randomized trial, and the Dutch pancreatic group have a worldwide reputation in delivering these kinds of trials, and we're going to hear from one of our colleagues next. So this paper was published in 2010, New England Journal. They randomized patients who were jaundiced with a resectable pancreatic tumor. They randomized them to preoperative biliary drainage versus straight to surgery. So the minimum bilirubin was 40, but they had an arbitrary cutoff of 250 micromoles per liter because they felt that bilirubin higher than this was associated with significant risks. But we can come back to that. And their primary endpoint was what they termed serious complications, which was significantly higher in the preoperative drainage group, so about twice as high. And if you look at the tables, it's going to be difficult to read, I think, but a lot of the morbidity in the biliary drainage group occurred before the surgery. So it wasn't necessarily post-operative morbidity, it was preoperative morbidity, and some patients didn't get to surgery. One other factor they identified was it took longer. So once you've drained the patient, you have to wait for the jaundice to clear, and then you operate. And the time to surgery was 5 weeks in the drain group versus a week in the straight to surgery group. So the conventional approach is the patient comes with jaundice, you do an ERCP, put a stent in, you then find out that it's not a stone. You identify a stricture, you do a CT scan, find a tumor, decide it's resectable, go for surgery. The fast track approach is the patient comes with jaundice, painless jaundice, you do a CT scan, you diagnose a resectable tumor, you operate on the patient without a stent. So that's fast track surgery. So we decided probably about 9 years ago to implement this pathway in our centre. So we do approximately 130, 150 Whipples a year in Birmingham. And we wanted to try to change our practice because the practice was ERCP followed by surgery. So we received referrals from a sort of geographical area, and clearly these patients are referred from gastroenterologists who will have put stents in first. So we had to challenge that and try to re-educate and change practice from that perspective. We also had to deliver surgery within a short time frame. So we can't leave patients with jaundice for weeks and weeks. We have to operate sort of in a timely manner. And we had to challenge concerns that maybe some of our colleagues or some of the anaesthetists had about operating on jaundiced patients. So the barriers, so the established practice in secondary care, we went out to educate the gastroenterologists about the evidence, and we engaged with them about the process. One advantage I think in the UK is that gastroenterologists do not do ERCPs for financial gain. They did it because they thought it was the best practice. So it took a while to educate and change practice, but we established a pathway where they found a patient who was jaundiced, they did a scan, then called us. And then we had a nurse who then took that further. We got it discussed outside the MDT. We didn't wait for the MDT. We had it discussed with a radiologist, made a decision. Is this patient resectable? Yes or no? Are they fit enough? Yes or no? They didn't stay in hospital. They went home, came to the next clinic and had an operating list scheduled usually the following week or the week after. And we left at that time. We left one theatre. We have 10 operating lists a week in our hospital. We left one operating list empty every week for these patients, and now we leave 2 empty lists. We also engaged with radiologists to explain what we were trying to achieve, and now we do liver MRI scans in all our fast track patients. We do selected biopsies, EUS biopsy, and again we can get EUS done within a week and urgent analysis of the cytology. Trying to educate anaesthetists. Are there any anaesthetists here? Trying to educate anaesthetists was difficult. Okay. So this was our first paper we published on this topic. And one of the interesting things we found, so we didn't have a cutoff. We didn't have a strict cutoff for bilirubin. We just kept pushing. So the traditional teaching is that bilirubin goes at 100 micromoles per liter per week. But the trend varies quite a lot between patients. We found that variations in the rise of the bilirubin. So we'd monitor the bilirubin, and in patients who had kidney injury or cholangitis, we wouldn't go straight for fast track surgery. But if they were fit enough, and if they're a resectable tumor, we would do a fast track surgery. So one thing we found was the time from the first CT scan. This was a historical cohort, so preoperative drained group, 60 patients. The time from CT scan surgery was 2 months, which is quite a long time. In the fast track pathway, so CT straight to surgery was about 2 weeks. So of significant improvement. And one thing that was associated with was a higher resection rate. So in the pre-op biliary drainage group, about 25% were not resected. So they had a laparotomy, and then they had a bypass because they had advanced disease. So that was 25% bypass rate in the drain group, and only one out of 32 in the fast track group had bypass. There was a higher vein resection group in our fast track series, and that probably reflects some change in practice towards being more aggressive, doing more vein resections over the time period. Complications, post-op complications were similar. So this is fast track surgery is safe. It does not expose patients to risk, and we found that the actual surgical procedure was easier in patients who haven't had a stent put in. There's less inflammation around the hilum, and it's just more pleasant operation. So decreased time to surgery, higher resection rate in the fast track group, but also a higher vein resection rate. Published that data, and other centres have published similar results. So Manchester published this a couple of years ago, and a Dutch group looked at the cutoff value for bilirubin and looked at high versus very high bilirubin and didn't find any difference in terms of post-operative morbidity. So as I said, in patients who have AKI, we will put an external drain in rather than an ERCP stent, wait for the kidneys to improve and then operate. We looked at long-term survival in patients who had fast-track surgery, and the first survival curve is the dark line, the solid line is the pre-op biliary drainage, and the fast track group is a dotted line, so better survival. But if you then divide the pre-op drainage group into those patients who had resection versus not, and so that's the critical point. Some patients who are having pre-op biliary drainage are not getting to resection or having a bypass, and they obviously have worse survival. So the point is, if you do a fast track surgery, you're more likely to resect them and therefore give them better survival. And there's some reasons why patients would fall off the pathway in the biliary drainage group, including complications from the stent. We looked at cost as well. So we looked at patients who had, rather than compare stent versus no stent, we compared patients who had rapid surgery versus delayed surgery, looking at quartiles. About 40% in the early surgery had been stented versus all of the patients in the fourth quartile. And there were, obviously, as you'd expect, there were higher unplanned hospital admissions in patients having delayed surgery, and this really translated into a higher cost. And the cost difference was about, well, in this study, over €3,000 difference. The resection rate, as I mentioned, was different according to the timing of surgery. So, nearly finished. So NICE guidelines were published in 2018, and in NICE guidelines they said they recommended offering resectional surgery rather than drainage to people who have resectable pancreatic cancer and jaundice and are well enough and not enrolled in a clinical trial. And the upfront surgery leads to a cost saving of £2,500 per patient. So in summary, upfront surgery for resectable pancreatic cancer in jaundice patients is safe. The bilirubin value does not affect outcome. Only stent or external drains in patients with AKI or cholangitis. There are some logistic challenges and cultural challenges in order to change practice, but it's possible if there are people driving the process. And importantly, upfront surgery reduces hospital costs. I think my next speaker is going to be talking about neoadjuvant treatment for resectable disease, and I think in recent years, with the advent of FOLFIRINOX as a chemotherapy agent, we're finding that certainly for borderline resectable disease, these patients are getting chemotherapy, and now, you know, the time will tell which patients with resectable disease should be offered neoadjuvant chemotherapy. I think the issue is that any trial that is designed to look at the effectiveness of neoadjuvant treatment for resectable cancer should be compared with fast track straight to surgery, not stented patients. Thank you.
So if we can start the presentation for Bas Groot, because he's sent the presentation. So this is an online presentation, and like Mr. Robert Sutcliffe explained, the indications for chemotherapy versus no chemotherapy are different. So we can start the presentation, please, for Bas Groot.
Hi everyone, I'm Bas Groot. I'm a surgeon at the Erasmus Cancer Institute, Rotterdam in the Netherlands. Today I'm going to talk about neoadjuvant chemotherapy for resectable pancreatic cancer. And I'd like to thank the organizing committee of the Shaukat Khanum Cancer Symposium for the kind invitation. To describe the scope of my talk today, I would like to start with staging of pancreatic cancer. And in particular, staging pertains to the venous and arterial abutment of the tumor on imaging. And the focus of my talk will be patients with potentially resectable disease and borderline resectable disease. And if you look at the NCCN guidelines, you'll see that venous abutment is allowed up to 180 degrees for potentially resectable disease, and any venous contact is allowed for borderline resectable disease. Regarding arterial contact for potentially resectable disease, no contact is allowed, and for borderline resectable disease, the contact is limited up to 180 degrees for SMA and celiac artery, and any contact is allowed for the common hepatic artery. And the terminology for the chemotherapy in these patients is neoadjuvant or adjuvant chemotherapy. So both locally advanced cancer and metastatic cancers beyond the scope of this talk. So historically, these patients underwent upfront resection. And unfortunately, the results with upfront resection are rather bad. If you have an amazing pathology who really meticulously looks at your resected specimen, the risk of an R1 resection is 85%. Most patients who undergo a resection develop a recurrence, and 25% develop a recurrence within 6 months. If you look at the adjuvant arm of a neoadjuvant trial, for example, the PREOPANC-1 trial or the ASPECT-5 trial, the median overall survival of an upfront surgery approach is as low as 11 or 14 months. And finally, it's important to realize that although we as surgeons like to believe that we cure patients with pancreatic cancer, this is exceedingly rare if we look at 10-year survival. It's only about 3%. And the main concern explaining these poor outcomes of upfront resection is that the majority of patients will not receive adjuvant systemic chemotherapy. If you look at population-based studies, this barely exceeds 50%. So in summary, what is the rationale for a neoadjuvant approach? The number one is that all patients will receive systemic chemotherapy. And number two is that futile surgery is avoided in patients with rapidly progressive disease. What do the guidelines say? Fortunately, we have very recent guidelines. The European guideline of the Society of Medical Oncology was just published in September. And for potentially resectable disease, the recommendation is to do neoadjuvant treatment only in clinical trials. So the default for potentially resectable disease is still upfront resection. For borderline resectable disease, there's a strong recommendation for a neoadjuvant approach. The NCCN guidelines have a similar recommendation, although they do recommend neoadjuvant approach also for potentially resectable disease in high-risk patients. And these are defined, for example, with a high CA19-9 count. The only phase 3 trial that has completed full accrual investigating and comparing a neoadjuvant approach with an adjuvant approach in patients with resectable or borderline resectable pancreatic cancer is the PREOPANC trial. This was published 2 years ago, and last year we published the long-term results. 246 patients. The comparator arm was the standard arm at that time, the adjuvant gemcitabine 6 cycles, and the intervention arm was gemcitabine with radiation in the neoadjuvant setting, and in the adjuvant an additional 4 cycles of gemcitabine. Overall survival was the primary outcome, and as you can see here, the long-term results clearly show that the neoadjuvant approach was superior with a hazard ratio of 0.73. And especially at 5 years, there was a clinically relevant difference of 6.5% with upfront surgery versus 25.5% with a neoadjuvant approach, resulting in a number needed to treat of 7. In a meta-analysis, we confirmed these results. In this meta-analysis, we found 7 randomized controlled trials with a total of about 1,000 patients. Again, all these trials compared a neoadjuvant approach with upfront resection. 98% of patients had gemcitabine-based treatment. That is important to realize. So all these studies are relatively old and rarely included patients who underwent FOLFIRINOX chemotherapy. Moreover, it's important to realize that 5 out of 7 trials, one of the intervention arms included neoadjuvant radiation. If you combine all these trials together, the hazard ratio was 0.66 with a p-value of 0.01, clearly showing superiority of a neoadjuvant approach. More recently, the ESCO presented the NORPEC trial. And in this trial, which was performed in 12 Nordic centers, with a sample size of 140, patients were included only if they had resectable pancreatic cancer. In the intervention arm, patients had 4 cycles neoadjuvant and 8 cycles adjuvant FOLFIRINOX. And in the comparator arm, they had 12 cycles of adjuvant FOLFIRINOX. The primary endpoint was overall survival, and I think to many people's surprise, if anything, the survival appeared to be better in the adjuvant setting. Although the study was not powered for definitive conclusions regarding overall survival, as was also demonstrated by the p-value. Moreover, the study has been criticized because only 60% completed at least 4 cycles of neoadjuvant FOLFIRINOX. To definitively address the question whether for resectable pancreatic cancer, neoadjuvant FOLFIRINOX is better than adjuvant FOLFIRINOX, 2 trials are investigating this: the Alliance trial in the US and the PREOPANC3 trial in the Netherlands. Both studies have a similar sample size and identical regimens in both the standard arm and in the intervention arm. The current status is that both trials have included more than 50% of the required patients. The next question, obviously, is if you do a neoadjuvant approach, what is the best regimen? And although in the adjuvant setting and in the metastatic setting, FOLFIRINOX seems to be the superior approach compared to gemcitabine-based chemotherapy, this is not necessarily true in a neoadjuvant approach. And the first trial that investigated is the SWOG trial with 100 patients with resectable pancreatic cancer. And they were randomized between 6 neoadjuvant cycles and 6 adjuvant cycles of FOLFIRINOX versus 3 neoadjuvant versus 3 adjuvant cycles of gemcitabine with nab-paclitaxel. And as you can see, the results were exactly identical. The PREOPANC2 trial was a phase 3 trial that also compared 2 regimens. Again, an intervention arm, this time with FOLFIRINOX as total neoadjuvant treatment, so 8 cycles without adjuvant treatment. And in the standard arm, basically the winning arm of the PREOPANC1 trial, which was gemcitabine with radiation in the neoadjuvant setting and gemcitabine alone in the adjuvant setting. And this trial was presented last month at ESMO, and I'll just go through with you briefly to the results. The baseline characteristics showed that they were similar in both arms, and important to see is that about a third of patients had borderline resectable disease. Regarding study treatment, almost all patients started with their scheduled neoadjuvant treatment, and but the completion of all scheduled neoadjuvant treatment was smaller in the FOLFIRINOX arm with 8 cycles scheduled, although 81% received at least 4 cycles. A resection was performed eventually in both arms in about 75% of patients. In the gemcitabine arm, 72% of patients also underwent adjuvant treatment. This is the overall survival curve, and as you can see, they are largely overlapping. We had no loss to follow up in the first 2 years, and this resulted in a hazard ratio of 0.87. And the difference between the 2 arms was not statistically significant. The median overall survival was about 21 months in both arms. As you can see, the long-term follow-up is still immature, and it's still possible that the FOLFIRINOX arm will turn out to be superior. How about the pathological examination? Clearly, in the radiation arm, the gem-based radiation arm, patients were more likely to have a node-negative resection. A margin negative resection was comparable in both arms, and a complete pathological response was also comparable. What about toxicity? Serious adverse events were comparable in both arms, as well as grade 3 or grade 4 adverse events. And if we look in more detail of the grade 3 and 4 adverse events, diarrhea was clearly more common in the FOLFIRINOX arm, as was febrile neutropenia. So what about radiation? In the PREOPANC1 and PREOPANC2 trial, radiation is combined in a neoadjuvant setting, but it has not been investigated with and without radiation. The most important recent trial regarding the potential additional benefit of radiation is the Alliance trial that was published last year in JAMA Oncology. This was a trial only for patients with borderline resectable pancreatic cancer, and patients all were scheduled for neoadjuvant FOLFIRINOX. However, in the group who had also SBRT, the SBRT was followed after FOLFIRINOX. And I think quite surprisingly, survival was worse in the arm who had additional SBRT. It was considerably worse. And although this was a relatively small arm, I think this shows that these patients are unlikely to benefit from radiation. So in conclusion, ladies and gentlemen, survival is better with neoadjuvant gemcitabine-based treatment compared to upfront surgery. Overall survival for neoadjuvant FOLFIRINOX versus gemcitabine with nab-paclitaxel or radiation, as in the PREOPEN-2 trial, is similar. We've seen disappointing results in the NORPAC trial on neoadjuvant FOLFIRINOX for resectable pancreatic cancer. And we've also seen disappointing results on neoadjuvant SBRT for borderline resectable pancreatic cancer in the Alliance trial. And I think we're all awaiting the PREOPEN-3 and Alliance trial comparing adjuvant versus perioperative FOLFIRINOX, and both of these trials have accrued more than 50% of required patients. I will just highlight one topic because I was asked for the discussion to address the question, what would you recommend in a healthcare setting with limited resources? I think the standard of care treatment for pancreatic cancer currently does not involve expensive immunotherapy or targeted treatment. I think that surgery is probably the most expensive part of the treatment. And I think one advantage of a neoadjuvant approach is that it avoids futile surgery in about 1 in 6 patients. Regarding the preferred systemic regimen, I assume that FOLFIRINOX will be more expensive than gemcitabine in most settings. And I think with the data from the SWOG trial and the PREOPEN-2 trial, gemcitabine alone, and maybe with nab-paclitaxel, which of course is much more expensive. Excuse me. Which is much more expensive. I think still, nevertheless, gemcitabine alone is a fair regimen in the neoadjuvant settings. So although in the adjuvant setting, FOLFIRINOX is clearly superior, same is true for the metastatic setting. I think in the neoadjuvant setting, in a setting with limited healthcare resources, gemcitabine is a fair option. And I think radiation has no clear benefit. Many studies have failed to demonstrate a benefit, and it's also expensive. So I think this should not be the focus or necessarily part of treatment in a resource-limited healthcare setting. I'd like to thank you very much for the opportunity to present, and I'm happy to address any questions.
Thanks very much. I'd like to introduce the next speaker. It's my pleasure to introduce Professor Khan from Aga Khan University Hospital. He's a hepatobiliary surgeon and the Associate Dean of the university. He's going to talk about evolving paradigms in gallbladder cancer.
Thank you very much. Good afternoon. Thank you for the invitation, the symposium organizers, Irfan in particular, and thank you, Mr. Circular, for the kind introduction. I'm going to talk about gallbladder cancer, which is relatively uncommon disease as compared to everything that you have seen since morning, including upper GI, colorectal, pancreas. So this is not very common. The other problem that we have with the gallbladder cancer is the obvious lack of level 1 evidence as far as treatment options are concerned. So with these limitations, I'll try and summarize some of the important or controversial issues on the gallbladder cancer. Despite the limitations, gallbladder cancer is still the most common biliary cancer. And even in the Western world, this is one of the fifth most common GI malignancy. The problem with gallbladder cancer is that most of the time the presentation is delayed. and less than 1/4 of the people will get radical surgery. And that is why the overall survival is quite low as compared to other cancers of the GI tract. There is a typical geographical distribution. We still tend to fall in the hot area, although this doesn't say Pakistan, but Pakistan probably has a similar incidence as has India. I'll go, in the interest of time, I'll not talk about other things. I'll go mainly to the surgical principles of management because that is where the controversy is. And for the sake of benefit of the trainees, I'll cover the initial part as a management principles, and then I'll talk about the controversial issues. This is an important consideration as far as the management of gallbladder cancer is concerned. I'll talk about it in the subsequent slides. So if you look at the management of gallbladder cancer, and this is based on the stage, starting mainly from the T stage. So if the disease is very initial, is either in situ cancer or T1A, which means it only involves the lamina propria, the chance of lymph node metastasis in this condition is quite low. It's apparently less than 2%. And that is why a simple cholecystectomy may be an acceptable treatment option in this very early stage gallbladder cancer. Moving forward, if the tumor is involving the muscle layer, which is the chance of lymph node metastasis actually goes quite high. It is 14%. And that is why the recommendation is to do a much radical surgery. And the radical surgery here is a cholecystectomy, regional lymphadenectomy, and a hepatic resection, which is mainly segment 4B and 5. Moving further, if this is a T2 lesion, which can further be divided into 2A and 2B, depending on the location of the tumor, whether this is on the peritoneal side or on the liver side. Again, this is considered advanced disease, and operation is radical. Radical cholecystectomy, regional lymphadenectomy, segment 4B5 hepatectomy, and you might consider bilateral resection if the cystic duct margin is involved or the tumor is close. Moving further to a more complex situation, this is a T3 disease where the tumor actually perforates serosa and may involve liver or adjacent organs. And honestly, apart from the incidental gallbladder cancer, this is the type of cancer that you would end up seeing as a hepatobiliary surgeon in Pakistan in most of the situations. Here, again, operation remains more or less similar. You do a radical cholecystectomy, which includes removal of gallbladder, regional lymphadenectomy, a segment 4B5 hepatectomy, and bile duct resection if the duct margin is involved, and also in block resection of adjacent organ, because this is now T3, which means the other organs are involved. And this will depend on which organs are involved. This may involve, for example, not just 4B5, but maybe extended hepatectomy. Maybe in certain cases, the tumor may involve the whole or a significant length of the bile duct or the margin of the porta, and you might end up doing a hepatopancreatobiliary, which is a quite extensive procedure, which is still a high mortality, not just morbidity, a very high mortality. Overall prognosis in this situation, for example, may not be very good because of the high morbidity, and the surgical resection is recommended in highly selected cases. Moving further, T4, where it involves hepatic artery, portal vein, or at least 2 or more extra hepatic sites. This is a significantly complex surgery with maybe requirement for vascular resection, reconstruction. And whatever you do, generally the prognosis in this situation is not going to be optimal. It's going to be less than optimal. And that is why this must be, I mean, all the cases should be discussed in MDT, but this in particular will need a discussion about the prognosis and outcome, and you might consider new adjuvant, the role is limited, or maybe palliative care if the patient has poor outcome to begin with. The survival will, of course, depend on the type of disease you have or the state of the disease you have. If this is early T1A or TIS, it's a very good 5-year survival. And up to the T2, you might look at a reasonable survival, but beyond that, survival is significantly low for this disease. If this is unresectable with palliation, you are talking of a few months here and there. So are the things really changing? as far as the management of gallbladder cancer is concerned. We'll just try to look at some of the aspects, so whether there's a change or no change. And as I said before, the problem that I face here is the lack of level 1 evidence, for example, in pancreatic disease or colorectal cancer that you had. So most of the data is actually retrospective that we have here. So looking at this again, first of all, let's talk about the incidental gallbladder cancer. If this is, which is approximately half the cases that we see because of the lap cholecystectomy. If this is T in situ or 1A, there's no debate. If the cyst duct margin is negative, you have done cholecystectomy, which is good enough. I'll leave the T1B for now, and I'll talk about T2 and T3. Again, there's not much controversy. You follow the standard recommendation, which is a radical cholecystectomy, lymphadenectomy, and resection of liver. And if you do this, you actually can get a reasonable outcome in this incidental gallbladder cancer. The problem is with the T1B tumor, where there's some debate. T1B, the standard recommendation, again, I would emphasize, is the radical cholecystectomy, as I said before. But is there a role for simple cholecystectomy even for T1B? And just to remind you that here the chance of lymph node metastasis may be up to 14%. So first of all, is this recommendation being followed? So there is some data from the National Cancer Database in US, which looked at a number of years of data. And when they looked at whether this recommendation was being followed or not, it's actually only 50% of the cases where radical procedure was performed, which means in another 50%, this recommendation was not being followed at all. So there's an issue of compliance. But moving forward, there are a number of studies which have looked at whether simple cholecystectomy may be feasible in this given situation. And now I'll not go through all this data, but if you look at, people are probably trying to select out who are the suitable candidate for a simple cholecystectomy as compared to a radical cholecystectomy in T1B disease. I'll just ask you to focus on this last line. So in this data, which is a C data about roughly around 300 T1B cases, over a period of almost 10 years, and they thought that simple cholecystectomy were adequate treatment for tumors which were less than 1 centimeter, which means essentially very small disease, not for the others. And again, this is a lot of a big data for a good number of cases. Again, they looked at the feasibility of simple cholecystectomy versus radical cholecystectomy. Here, they did not find any significant difference in overall and disease-free survival between different types of procedure in patients who had grade 1 T1B. But of course, for anybody else, which was grade 2 and above, there was obvious survival difference. So even in this case, if this was, for example, if I summarize, if this was a small tumor less than 1 centimeter and the grade was early grade, you might consider. But is this really recommended? Actually, can't say for sure. And the main reason is that this is retrospective data and many confounders may be there. There are some guidelines which are emerging that maybe simple cholecystectomy can be an option, but others are still recommending radical cholecystectomy. Very quickly moving forward, I know the limitation of time here, so I'll try and finish quickly. Is there a role for post-cytic scene, again, in incidental gallbladder cancer? This was a routine in US and many other places, but now there's emerging data and probably convincing data to say based on number of retrospective studies that this is not really required. And probably the things which have changed is the delivery of gallbladder using bags and many other things in the incidental gallbladder cancer. Timing for reoperation. When do you operate? After you have done a laparoscopy cholecystectomy and you find a gallbladder cancer. Again, not much convincing evidence to say whether early versus late, but most of the data suggests that if you do early, outcome may be better. And most of the studies recommend few weeks, which means 2 to 4 weeks or 4 to 8 weeks. So early resection is preferred given whatever the evidence we have in this situation. Now, moving forward, about the T2 and T3, we know that some sort of liver resection is recommended. The question is whether you do only a wedge resection, which means you remove another 2 or 3 centimeters of gallbladder, liver around the gallbladder, or you do a formal 4B and 5. Again, there's a controversy. For example, Chinese guidelines say it will depend on the stage of the disease. different for T1B, T2A versus T3 and moving forward. So not much convincing data, but generally, for example, this is a multi-center retrospective review of studies. It says probably whatever you do doesn't make much of a difference. So you must remove at least 2 to 3 centimeters liver. And I would conclude that there's not much data to say which one is better, but at least a microscopic negative margin is the minimum requirement for this given situation. Extent of lymph node, you must do a lymphadenectomy, and AGCC staging requires at least 6 lymph node. But you look at the real data that we do, the data after radical cholecystectomy, the median number found in various studies is actually 3. So are we really following these guidelines? I mean, this is a question that we need to basically answer as a surgical person. There was a debate, laparoscopic should not be done in gallbladder cancer. I think this is all settled now. Laparoscopy is now one of the methods that can be used even for a known gallbladder cancer, provided you can do an in-block resection and take the tumor out without contaminating the field. Is there a role for neoadjuvant? There is almost no data. There's data for adjuvant chemotherapy, for neoadjuvant, probably only retrospective studies, so I can't say for sure. And I would also caution against using adjuvant chemotherapy for all cases. Probably we need to identify people who will have poor prognosis irrespective, so they may still be excluded because this disease usually presents in the advanced stage. I think this is probably the last of my slide. There is an emerging role of immunotherapy in gallbladder cancer. There are a number of targets, particularly, for example, P53 has been identified as one of the target area. Of course, this is not a solution for everybody with the gallbladder cancer, but a number of pathways have been identified. And I think this may be a way forward. This is evolution in progress. We might see more of immunotherapy for gallbladder cancer as compared to probably other methods evolving. So thank you very much. I wanted to finish quickly, Irfan. I understand the time limitation. So thank you very much.
Spot on time. Thank you very much for that. So, ladies and gentlemen, we're going to skip on the last talk because we've got the plenary session starting next. But we've got time to take 1 or 2 questions. So if anybody's got any questions for the panelists, Dr. Rizwan's here and Mr. Saqib's here. So we have a question there.
Question.
And Guido is online.
Assalamualaikum. I have a question for Dr. Jamil, if you can answer, please. So thank you for the lovely talk. So as we know, in colon cancer, prognosis depends on several factors, including sidedness, MSI status, and molecular status. Would you be interested to know these all factors before deciding the synchronous resection, or you would just go for the resection approach?
So when we do the biopsy of the colonic cancer, we do have a immunochemistry profile for those patients. So we will have some information, not a lot, how the tumor biology is going to impact or going to behave. But these are one of the other factor which one must need to consider before offering surgery, either synchronous or a stage. And that's why one of the impacts, they say that you should do the primary first to know more biology and how it's going to behave, and go to the second stage as a liver.
Okay, thank you.
My question is from Dr. Rizwan. Is there any role of cystic duct node frozen section and followed by fate of lymphadenectomy according to that? As we decide the CBD excision on the cystic duct margin, is there any role of frozen section of cystic duct node with deciding the lymphadenectomy in diseases more than T1B?
So I think you can consider frozen, but I don't think that would change your overall management. You must do lymphadenectomy along the cystic duct, along the bile duct, along the hepatic artery, and maybe up to the celiac axis. So you need to take all the nodes out. If that node is positive, would that change your course of plan of surgery? probably answer is no. So this may add more time to your procedure, but even if this is positive, this patient will likely need adjuvant treatment, but the plan of surgery probably will not change. So the concept of sentinel node, I don't think it's very much established as far as gallbladder cancer is concerned. So you might think about it, but there's not much literature that I would say would support the idea. So the concept may be there.
Question with Mr. Robert Sertler. Just we had cut off for bilirubin for phosphate one, it was around 250 and 300, even when we were working with Minder. And now there is no limit, cut-off limit, and we have done resections, pancreaticoductomy in patients with bilirubin more than around 350 and 400, as you shown in your series. Just give me some tricks of the trade that how we can reduce the morbidity in such patients by any surgical strategies or like any post-op care especially. Thank you.
Thanks, Nasir. Yeah, I mean, we've sort of gradually pushed up the bilirubin level, realizing that it doesn't really impact on the outcome. I think patients are usually outpatients before the surgery, but we admit them the day before and give them intravenous fluids overnight to maintain hydration. That's one thing we do. Surgical technique is the same as any Whipple's. I think these patients have a lot of fluid losses in the perioperative period, probably more than a standard Whipple, and so it's intraoperative fluid replacement and postoperative replacement. Yeah.
Thank you. Thank you.
I think that's about all the time we have before the next session starts. So Guido, thank you very much for joining us from Italy. I appreciate your talk, and you've gotten off easy without any questions. So lucky day for you. And thank you very much for joining us. And the same for the other speakers, Mr. Jamil, Professor Rizwan, Mr. Sutcliffe. I appreciate the talk. It's been very controversial topics we talked about. We still may or may not have an answer to the questions. Time will tell. It just shows the complexity of the decision making that we have to deal with on a daily basis with all patients related to HPV. So thank you very much to the audience as well for joining us. I hope it's been educational. Thank you.